Okay, do you see my screen? Okay, I'm gonna scroll through these images. There's a lot of pathology, so I will withhold the history for a second, but just looking at these images, any initial thoughts? It's a middle-aged male patient.
Guys, send in your thoughts to the chat and I'll read them out. So you said it's an older patient?
Middle-aged, 50.
And what the irrelevant history?
If I tell you the history, it'll make it a lot easier, but let's get some differentials. If we were reading with no history, what sort of differentials would we have thought about? And then once I tell you the history, it will make more sense.
Okay. So, nobody wants to chime in, so I guess I'll be it.
Everybody in my group knows it, so you'll have.
Well, I mean, it's an kind of almost infiltrative mass in retroperitoneum. It involves the kidney. Looks like it encases the aorta, obstructs the aorta. Whenever I see something like this, my first thought is lymphoma.
Sure, that's all.
Although in some of the images it look a little too heterogeneous, unless you tell me that this patient had treatment from lymphoma.
Victoria, I cannot hear you. You're breaking off.
I'm sorry?
I heard lymphoma. After that, I didn't hear anything.
Oh my goodness.
I said, would this appear? Can you hear me better now?
Yes.
Okay. So my thought was lymphoma because of its infiltrative kind of appearance and encasing structures. The only thing that concerns me for lymphoma is that it's a little heterogeneous. Usually lymphomas are much more homogeneous, but maybe this patient had treatment for lymphoma, in which case it would be perfect.
They've not been treated for lymphoma, but they're being treated for myeloma.
For what?
For myeloma, multiple myeloma.
For myeloma. So this is plasmacytoma then?
So this is extensive extramedullary disease, which if we see outside of a bone, extracortical, and more often solitary, we call those plasmacytomas. But this is more like a hematogenous spread of multiple myeloma as extramedullary disease. So where we practice is a big myeloma center. So every variant of myeloma there is. So
did this patient have bone involvement?
they had all kinds of involvement, and I'll show you different. So this has been progressive. This started out as a small renal, like a pararenal fascial lesion, and then it's blown up this extensive retroperitoneal, and now I think there is even intraperitoneal extension because we see soft tissue nodules here in the transverse colon mesentery, here anterior to the pancreas. The duodenojejunal junction looks like it's going to be involved, and it's reaching beyond the anterior pararenal space and out into the small bowel mesentery, going along this lateral corneal fascia. A very extensive extramedullary disease. A few other differentials in this patient population to think about are amyloidosis, systemic amyloidosis, something like this where it will cause these masses. But even
Roopa, your volume is too low. We can't hear you at all.
I'm speaking at my highest. Is this better?
A little bit.
Better?
Not really.
Screaming at the top of my voice.
Roopa, your speech mic might have gotten disconnected.
Can you hear me at all?
Very little.
Like as if you're really far away from the mic.
Yeah. Check the connection of your speech mic.
Let me do this. Let's join Zoom to my phone and do it. Maybe that will.
But whatever you did, it got worse.
Oh no, hold on. How about this?
A little better.
How about this? I've changed my entire output. Can you hear me now?
It's better.
Okay, hold on. Hold on for just a second. Okay, can you hear me now?
Oh, perfect. Except for now there's feedback.
Okay, is this better?
Perfect.
Okay.
Feedback. Oh.
Sorry. Okay, so yes. So valid differentials would have been amyloidosis, but again, much more homogeneous masses with those very low on T2 signal-wise. You don't expect this much heterogeneity. Treated lymphoma, yes, can look variable, and these patients are always at higher risk of second malignancies like round blue cell tumors or some treatment-induced changes even. Something like very bad variant of IgG4 type deposition disease can look like this. So those would all have been valid differentials, but being from a very heavy myeloma population place, we've seen a bunch of variants of extramedullary disease. And let me just share this PowerPoint. Okay, let's do this. Okay, so EMD in myeloma is a described entity. It is, if it's contiguous from an adjacent bone, it's usually a soft tissue with a contiguous bony lesion, or it's hematogenous many times. And in newly diagnosed patients, it's up to 15% and 20% in relapsed cases. Tends to have a poorer prognosis when you see EMD, especially in as a relapse feature. And we spoke about our differential. So just to show you few examples of what we've seen over the years, sort of targetoid liver lesions, very early enhancement can be mistaken for some kind of arterially enhancing liver lesions, but then after treatment, the enhancement goes away. Some of the lesions even go away. So most of these do get a biopsy. PET scan is very sensitive to pick up more and more of these lesions, but many of them do get biopsied. This one was in the splenic hilum, very infiltrative lesion here in the splenic hilum, which disappeared after treatment. This one even had involvement of the abdominal wall musculature, which didn't change a whole lot. So variable responses to treatment is also usual with these lesions. This one was along the greater curvature of the stomach, endoscopically got biopsied, and then resolution at follow-up. These are hard. This was circumferential around the gallbladder fossa, enhanced very homogeneously, so can be mistaken for primary malignancies if this is an isolated site of involvement. So we've seen it in all weird places. This one again involving the pancreatic head, causing upstream biliary dilation, but then follow-up scans showed that all these went away. And this is similar to our kidney lesion. So there's a smaller one, again, very easily mistaken for primary, like a papillary RCC or something, and then goes away with treatment. Some other weird locations we've seen are in the knee, presenting as subcutaneous soft tissue masses. Again, biopsy proven extramedullary disease. And then this one was the sort of the worst one, and a big mimic in the scrotum adjacent to the testicle. You can see both on ultrasound and MR, and then follow-up images showing resolution. So in the spectrum of lesions where we say things can be a mimic, at least at our institution, we definitely keep extramedullary disease in the differential if it's a known myeloma patient. I think it's much like lymphoma, amyloid, which can mimic a lot of soft tissue masses everywhere. But they do well with treatment. Many of them regress. They wax and wane, but at least they do decrease in size if the appropriate treatment is initiated. So just a big spectrum of extramedullary disease.
This is really cool, Roopa. Thank you.
Yeah.
Are there any, like, I guess, are there any factors that predict if the patient has?
I think the genetics of these are very different. So they have done a lot of studies, and then they say patients who receive allogenic transplants have a higher risk of developing EMD as part of their relapse than those who receive autologous transplants. So I think a lot of it is genetics.
Very cool. And then if they get treated and the soft tissue, all the soft tissue masses regress, is that kind of correlates with the response of the bone lesions, or they?
Yes, most of the times the marrow activity goes down at the same time that the soft tissue masses regress also.
Right. Thank
Yep.
you.
Thank you.
Does anybody else have a quick case to share? You can either speak or text or okay. All right. If nobody is has cases, I'm going to share. I have a few. Can you see my screen? Roopa, can you see my screen?
Yes,
Yeah.
Vic.
Okay. All right, so I have several cases. So the first case is, I forget how old this person was, it's irrelevant, but she was in the ICU, and you can see she has, it's interesting finding in the pancreas. So anybody wants to kind of chime in? Either unmute yourself and speak, or you can text into the Okay, so somebody says lots of hemorrhage, which is a common interpretation of this finding, right? So we have on T2-weighted sequences, the pancreas is enlarged. We have a lot of kind of fluid around the pancreas, and so this is pancreatitis, right? So then on T1, the pancreatic parenchyma is very, very bright. So normally pancreatic parenchyma is bright on T1, but this is a little too much. And then this is a subtraction images, and you can see that there's no enhancement. So often people say that this is hemorrhagic pancreatitis, but in reality, this is just pancreatic necrosis, and it's a coagulative necrosis, so that's why it's so very, very bright on T1 and relatively dark on T2. There's no conscious enhancement. So hemorrhagic pancreatitis may happen, is really uncommon. And one thing that tells you that this is not really a hemorrhage is because if you notice all the kind of almost the capsule of the pancreas is retained. So this is something that's really seen. You pay attention, if patients get there's a little bit too much noise. Can you mute whoever solves, please? Anyway, so this is a very, once you start paying attention, somebody said, why is coagulative necrosis better to one? A lot of proteinaceous material. I'm going to mute everybody. Okay, sorry guys. So there's a lot of proteinaceous material released into the extracellular
matrix. I'm laughing because somebody said proteinaceous crap. But this is all proteinaceous material. So you will see this in patients with who have pancreatic necrosis. You will see these findings also in the parapancreatic tissues. So you will see, if you have coagulative necrosis in the fat, you will see the same signal intensity. And just so you can see the follow-ups, patient had pretty much the entire pancreas was replaced by necrotizing tissue. Eventually, this necessitated, you can see, cystectomy placement, and finally, the entire pancreas was pretty much replaced by, oh, so sorry. It was pretty much replaced by fibrous tissue. So you can see just normal parenchyma is not there. So it's about 3 years after the episode. And you can see that the pancreas is replaced by really dark T2 hypointense tissue, which is fibrous tissue. You have a little bit of residual collection in the place of the body. You can see scarring kind of obstructing the common bile duct. So this is just a very extensive case of necrotizing pancreatitis. And again, this T1 hyperintensity should not be confused with hemorrhage. Okay, so the next patient had a history of chronic pancreatitis. And then this is, I'm going to withhold the history, but this is the scan that the patient had in the ICU. So either you can unmute yourselves or just text me your thoughts or send the thoughts through the group chat. Okay, so I'll just start pancreatic or biliary fistula. That's one thought, right? So we have just a lot of what looks like free air and foci of air around the stomach. You can see in the splenic parenchyma, in the liver, in the lysis sac around the celiac. You can see that the pancreas isn't really enhancing. Maybe there's a little bit of parenchymal enhancement and residual in the neck. Right, so those are great thoughts. Another thoughts come in: necrotizing pancreatitis, pneumobilia from the pancreas, all fantastic thoughts. But I'm going to give you now a little more history. So the history is the patient had a procedure, recent procedure. The procedure was endoscopic guided celiac neurolysis, and shortly after the procedure, she just had tremendous abdominal pain. So anybody wants to? So somebody said, is the gas free air or biliary and venous gas? So it's hard to know, right? But these are very peripheral, so we thought they're vascular. Additionally, you can see these geographic areas of non-enhancement. So we thought there are parenchymal infarcts. Okay, so anybody has any thoughts with the history of neurolysis, celiac neurolysis? I'll give a few seconds to think about it, and I'll just tell. This is a hepatic artery injury to a neurolysis. Very good. So this was a very rare complication. So what happened during neurolysis, and neurolysis is a technique where an alcohol is injected around celiac plexus, and this is kind of a procedure that's done for patients with chronic pain. Usually it's patients who have pancreatic cancer. In this patient, she had a lot of chronic pain from chronic pancreatitis. So this is kind of a last-ditch effort to try to kill the nerves and kill the pain. So what happened in this case is that the pure alcohol was injected into the hepatic artery into celiac axis. So what we thought, are foci of air, and perhaps some of these are foci of air, but most of these are actually foci of alcohol embolization from celiac artery. So you can see some of it went into the liver, causing liver infarcts. Some of it went into spleen, causing splenic infarcts. Some of these went into the pancreatic duodenal arcade, causing pancreatic infarct, causing duodenal pneumatosis, and then there's some so if you pay attention, right, these kind of foci of very low attenuation are inside little vessels, so they're not really free. They're in the little vessels around the area. Yikes. Yikes is correct. So this was a very rare complication of this procedure, where pure alcohol was injected into the artery and caused pretty much embolization and severe infarcts of the upper abdominal organs. And unfortunately, the patient did not do well after this, as you can imagine. Okay. My next case is a 12-year-old girl, and I'm going to withhold the history. So we have a sagittal T2, we have axial T2, and then post-contrast T1, and I'll just bring up the axial T1 for your viewing pleasure. Okay. So anybody wants to chime in?
Can you scroll on the sagittals, please?
Yeah, I'll bring up sagittal post as well. Right. Okay. So vagina is distended, right? So we have this kind of T2 hyperintense mass filling the vagina and bulging out, right? So when we think about 12-year-olds with with bulging vaginas, of course we think about maybe imperforate hymen or something, but this is more than just blood. You can see that there's a lot of enhancement, kind of nodular. And it has a very interesting morphology of enhancement and septations. Almost looks like little rounded things. So somebody had a great thought of clear cell associated with DAS exposure. It's a great thought, but this is a 12-year-old, right? And DAS exposures are now pretty much non-existent, especially in this young population. But several people chimed in sarcoma botryoidis, which is what this was. This is a 12-year-old girl. She presented with kind of a discharge and vaginal bulging. This was the scan, and you can see this is a very kind of classic appearance for this condition. Let me see if I can bring up the. Here's a. Not very common, it's uncommon. So this is an interesting case that was submitted in 2 patients. And you can see the case that they're showing is virtually identical to the case that we have, where you see very T2 hyperintense mass with these kind of rounded septations. Botryoid is grape-like, so you can see it does have this grape-like structure. They're not common, but this, they have very high T2 signal intensity. They have heterogeneous enhancement. They may have areas of internal hemorrhage, and this is actually considered to be not the most aggressive form of sarcoma. It's usually it's most common in very young kids within first several years. So then, and in vagina, and then it's, you can see here it says in cervix during the reproductive years, but this was vaginal in this patient. Let's see. Okay. All right. So unfortunately, this patient didn't have diffusion, so I can show that. But I presume that it would be restricted diffusion in these soft tissue compartments. Okay, my last case is a woman who came in to the emergency room with pain, and during the study, an astute radiologist picked up this kind of subtle hypodense area in the liver where, they said could be a lesion, could be an area of focal fat. So the patient went and had an MR, and you can see that the lesion is there, and in segment 4, you can see kind of ovoid. It does show signal loss on the out-of-phase images. So this was read as an area of focal fatty infiltration. I'll show you the rest of the study. Right, Kedar got the diagnosis, but so this was read as favor focal fatty infiltration. I forget for what reason they said consider follow-up, but they said confirm with get acetate enhanced MRI. So this is what they felt like, that this was a kind of an area of focal fat infiltration, but confirmed with EVIS. So about 6 months later, or so 8 months later, patient came back and now had MRI with get acetate. Now you can see it's a little more obvious that the lesion actually enhances on the arterial phase. So we don't really expect that from the focal fat infiltration. And then you can see also that it kind of drops the signal on the portal venous phase, and this is true for both extracellular contrast and get acetate. So enhancement washout, there is fat, as we saw, so it's a fat-containing lesion, hypervascular. So a bunch of you suggested this is adenoma, and this is what I also think it is. You can see that on hepatic biliary phase images. Clearly, the lesion does not concentrate EVIS, so it's naturally truly space occupying liver mass, not just a funny looking focal fat. Somebody said, did it enhance on the prior? It did a little bit. So for whatever reason, if you look here, it sort of does enhance, but you can see that it's a little, it's not very avid, so it potentially that's the reason why it was decided that this is not a lesion, this is a focal fat. I think with get acetate, the enhancement is a little more obvious, right? It's the differences may be because this, the follow-up study is a little bit just a touch earlier acquisition, so maybe the contrast has not started to move away from the lesion. Did it enhance on the prior? It wasn't enhancing that. Looks like, yeah, right. Right. So it's not an egregious miss, but I think that a little careful attention, you can see that there is change in signal. You can see that this is slightly washing out. one thing, so this was a little bit older patient, like 48, 49. In the she has no history of liver disease, but in an older patient, a slightly older patient, of course, we'll have to bring up the possibility of HCC as well, because HCC can totally look like this. Although probably, this ovoid shape is not typical. So we kind of gave the differential and said we favor, this is an adenoma, but you can't really tell for sure if it's not HCC. So we'll see if they're gonna follow it up, or they may biopsy this for confirmation. Or if the patient has clear history of of risk factors for adenoma, then they'll just assume that this is an adenoma and just follow it up. Okay, those are my cases. I'm going to stop sharing. Okay. Does anybody else have a case? Kedar, do you have anything?
No, sorry, nothing for today.
All right. Okay. Well, if nobody else has cases, we're going to finish early. But please bring cases, and you can see that it doesn't have to be very very fancy presentation. Just show us the cases, and share your thoughts, and you can make it as fancy or as low key as you want. And would love to see everybody's cases. Okay. Okay, I guess thanks a lot, guys, and
Thanks, Victoria.
thanks everybody. Thanks.